Well, hello and welcome to this month's podcast, where we're, as always, going to bring you up to date with the latest information and data in rheumatoid arthritis. Now, joining me today are two fellow members of the IMID Forum Steering Committee. Our first guest is Hideto Kameda, who is Professor of Internal Medicine at Toho University in Japan. And our second guest is Peter Nash, who is a Professor for the School of Medicine Dentistry in Griffith University in Brisbane, Australia. So I am absolutely delighted, Hideto, Peter, to have you joining me today. Great to see you. Thank you very much for taking time.
My pleasure.
Thank you so much,
Iain.
Good to see you. And for those of you who listen to these podcasts regularly, you'll know that one of my major preoccupations is the weather in Scotland. And we have just confirmed that even though it is midsummer here in Glasgow, Peter and Hideto have far better weather, whether they're in Europe or in Japan or in Australia. So let us commiserate with those of us in Scotland, but it does make us very robust. And of course, we do like a bit of light summer reading, which is what we brought to you, unless you're in the southern hemisphere, in which case it's a little light winter reading. But we've got a bit of that for you today. It's reviewing a paper that Peter Taylor and his colleagues have given us, which it's going to feel a bit esoteric, but don't worry, we'll get there. We'll talk a bit about the relevance of this, and it's to do with the neutrophil-to-lymphocyte ratio and the impact that might have on treatment response to filgotinib. So yeah, this is definitely in the department of information you didn't think you needed to know until we tell you, and then you'll realize that you probably wanted to know it. So as ever, to access detailed summary slides for the papers discussed today, please visit imidforum.com. imidforum, all one word, .com. So that's fantastic. Now, I think Hideto, you're going to give us the background to the study. So I'm going to hand over to you now to tell us what this is all about. Thanks very much.
Okay, thanks, Iain. The title of the paper is Patients with High Baseline Neutrophil-to-Lymphocyte Ratio Exhibit Better Response to Filgotinib as Treatment for Rheumatoid Arthritis. The study background: high baseline neutrophil-to-lymphocyte ratio, NLR, has been associated with positive responses to biologic TNF inhibitors and negative responses to conventional synthetic DMARD triple therapy in patients with rheumatoid arthritis. The phase 3 FINCH 1, 2, and 3 filgotinib trials represent three distinct populations of patients with rheumatoid arthritis at different stages of disease, namely FINCH 1 for MTX-IR, FINCH 2 for BioDMARS-IR, and FINCH 3 for MTX-naive patients. Investigators analyzed data from the three FINCH trials to investigate the potential association of baseline NLR with improved clinical response to filgotinib in MTX-naive FINCH 1 or MTX-experienced combined FINCH 2 and 3 RA populations. In all studies, oral steroids were permitted at a dose of 10 or less milligram per day prednisone equivalent, stable for at least 4 weeks. Patients were categorized as NLR high, greater than 2.7, and NLR low, not greater than 2.7. The main outcome explored in this study was DAS28-CRP. Other composite clinical outcomes included ACRN and CDAI. Patient-reported outcomes included Pain Visual Analog Scale, FACIT-F, Functional Assessment of Chronic Illness Therapy Fatigue, and HAQ Disability Index. Now, over to you, Peter.
Yep, Peter,
Thanks,
let's hear what we found. Crack on, sir.
Okay, so the results at baseline, it's important to recognize that the NLR high patients exhibited the following differences in comparison to the NLR low group. They had a high frequency of oral corticosteroid use, something like 10–11% more, a higher rate of seropositivity, again about a 6–8% difference, and a greater disease severity as measured by DAS28-CRP, and that's a controversial measure in JAK inhibitor therapy, and a higher HAC-DI. So they're a little bit more active on more seropositive and more steroid use at baseline. The MTX-naive NLR high patients who received filgotinib had a significantly larger improvement in DAS28-CRP when you compared that group with the NLR low patient group. They had more consistent improvements for filgotinib 200 versus 100, and the DAS28-CRP improvements in those patients on concomitant methotrexate experienced NLR high versus low were less, the improvements were less prominent in those who received adalimumab plus methotrexate compared with those receiving filgotinib. So the improvements in the MTX experienced high versus low, the differences were less prominent compared to a TNF plus methotrexate. The control arm in LR high patients showed a lower or similar DAS28-CRP remission, that's less than 2.6 response rate, compared to the NLR low patients. And those who received filgotinib 200 plus methotrexate and a conventional synthetic DMARD tended to show higher response rates. So many studies add methotrexate, you get a higher response rate. The number needed to treat to achieve DAS28-CRP remission less than 2.6 was consistently lower amongst the NLR high versus NLR low patient group who received 200 plus methotrexate on a background of conventional synthetic DMARD. So the conclusions that the authors made, the difference in response rate across this large number of patients in a number of clinical trials, across the clinical endpoints and the patient-reported outcomes over 12 weeks, placebo plus methotrexate plus conventional synthetic agent was control. NLR high had worse responses to NLR low. Filgotinib 200 plus methotrexate on a background of conventional synthetic DMARD, NLR high consistently better compared to NLR low, and these trends were most prominent amongst the methotrexate inadequate responder population, the group that we put onto a JAK inhibitor, and then it's a question of combination or mono over time. These findings support the predictive value of NLR as a biomarker for enriched responsiveness to JAK inhibition in RA. The 2.7 baseline NLR threshold could be used to identify patients most likely to benefit from adding filgotinib, particularly at 200 milligrams, to background methotrexate and conventional synthetic DMARD. The use of the baseline NLR as part of the therapeutic decision-making would not require additional diagnostic testing and could contribute to improved outcomes for patients with RA, and incorporating measurement of the NLR into routine evaluation of patients with RA may lead to more personalized treatments for patients with RA and to better clinical outcomes and patient-reported outcomes. They're the conclusions of the authors of this study, Ian. Over to you.
Yeah, well, thank you both. Crystal clear description of the study. Can we just take a couple of minutes to think out loud for a moment? And I'm not sure where I go with this, to be honest. The authors are correct because an NLR ratio can be calculated from routinely gathered data. But is their conclusion safe when half of the patients were on glucocorticoids? And I wonder if that is an indicator of disease activity. And of course, all medical students are taught, and we know in our discipline very well, that glucocorticoids change, amongst other things, neutrophil marginalization. And I have to say, I'm puzzled by this one. And I'd love to see what happens if you clear the glucocorticoid effect right out of this study. I'm just a little bit worried that we're looking at a biomarker of glucocorticoid use, which is in turn a pharmacomarker of disease activity and therefore a higher potential for a delta response. Listen, I'm just thinking out loud. Peter, what do you think? You've got that look in your eye, Peter.
I'm with you, Ian. I think that they've got to convince me that this is better than just showing very high disease activity with an ESR, for example.
Yeah.
And when I look at the number of diseases that affect the NLR ratio, someone I know very closely had to review this paper for the journal, and I went into Perplexity AI to ask the question, how many diseases are associated with a high NLR ratio? I was staggered by the number of diseases: cardiovascular disease, diabetes, any infection, malignancy, any chronic disease like obesity, coronary artery disease, acute conditions like trauma. So I think the NLR is very non-specific, like you were arguing, of demargination of neutrophils. And I think that until they show me that disease activity and ESR changes, that it's superior to that, I'm not quite sure what to make of this study, just like you, Ian.
I think you've made, actually, to be honest with you, I think you've made a better point than I did, Peter, which is, I mean, amongst other things, these different disease states are connected by endothelial dysfunction and therefore...
And inflammation.
Yeah, exactly. And by different potential for neutral migration. Hideto, any thoughts from your end? Is this used in Japan? Anything that you want to add to the evaluation of what we might do with this study?
Okay, thank you. The results are interesting, and NLR may be associated with the balance between innate and adaptive immune responses, but still not convincing for me enough because of possible many confounding factors, and the effect size is not satisfactory. In addition, only limited results are available. For example, how about ACR 20/50/70 responses, URA responses, and ACR URA Boolean remission rates? And how about just neutrophil count or lymphocyte count instead of NLR? If NLR high is associated with low lymphocyte count due to glucocorticoid or methotrexate or something, then how about the safety issue, including the risk for herpes zoster? So we need much more information before incorporating NLR into our daily clinical practice. What's your opinion about that?
I think you put it beautifully, and thank you also for bringing that comment. Particularly, I think we always learn from our Asian-based colleagues around virus risk and bringing that additional remark into the conversation. I think what I'm hearing is that this is, well, first of all, I think we have to compliment the authors. We're all trying to find biomarkers that will enrich response. So I think the motivation in the study and actually the presentation of the data are very clear. I think what is not yet clear is whether this is ready for prime time. In its favor, the simplicity is quite attractive, isn't it? But I suppose you've always got to ask yourself, well, what would the inverse be? If the patient didn't have a high NLR, would I be thinking I wouldn't go down this route? Well, I rather doubt it, because I've still got a patient theoretically with disease activity requiring intervention. And I just think you both have put your finger on it. We need more data. We need more data. But you know what, again, to commend our authors and our colleagues, they continue to put evidence into the literature, which we can use to develop the debate. And I think that is something to be hugely commended. So thank you both for your comments. It's terrific. And just to our listeners and viewers, if you want to look at the publications that we've uploaded this month and to access other podcasts and resources, head across to imedforum.com. As I always say, IMED Forum is one word. I actually recently had a colleague who said they tried to put imedforum one word.com on the internet and it didn't work. So IMED Forum, is a single word. Yeah, I know I'm not as clear as I should be. And always don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel. Such a thing exists, to make sure that you don't miss our podcast in the future. And as always, make sure to let us know what you think by leaving a review. And it leaves me only to thank Peter at Hideto. Thank you so much for sharing your expertise and your critique. I really value it. I always learn from these podcasts, so thank you for that. And thanks to you for giving us your attention. We hope that this is helpful to you in your clinical practice, and we look forward to seeing you sometime soon at another IMIDforum.com podcast coming your way. Take care. Thank you very much indeed.
Thanks, Iain.
Thank you.